Thanks, everybody. Welcome, members and guests of APSA. We really want to thank the program committee for allowing us to present our work that is part of our joint task force with the Society for Vascular Surgery and APSA. We do have a few disclosures. Dr. Nutrika is a consultant for AtriCure and KLS. We won't be discussing those today. And Cloudy, who is one of our vascular surgeons, is a consultant for GORE, but we won't be discussing that either.
So general concepts. So most of you learned about hard and soft signs of vascular injury during your training, but those are out. So what's replaced them is management based on whether either hemorrhagic injury or ischemic injury. And so they either have pulsatile bleeding or they don't. They either have Doppler signals or they don't. If they have an ankle brachial index less than 0.9, then obviously we're concerned about vascular injury. The study of choice now is CT angiogram with 3D reconstruction. If they are bleeding, we recommend operative intervention. And then consider compartment syndrome, which can also be a source of ischemia without being an arterial injury.
We're going to go through some of the most common injury sites. First, we'll talk a little bit about aortic injury. So aortic injury can happen in the thorax or the abdomen, though both are treated exactly the same way. You can see here there's some pictures of stent placement. Endovascular stent placement is the primary treatment for aortic injuries in both the thorax and the aorta. These were first developed in 2005, and you can see a CT angiogram on the bottom showing a stent that was successfully placed in one of our 16-year-olds that we saw just a few weeks ago. These are off-label use, but they are recommended by the Society of Vascular Surgery for first-line use for grade 2, 3, and 4 injuries. And you can see the grading system here just in case you hadn't looked at it in a few years. For abdominal aortic trauma, it's the same treatment. This has the benefit of allowing you to keep everything, to repair the injury without contamination. Most of these patients will have a coexisting intestinal injury, so it's important to do an endovascular repair if you can. You, of course, are limited based on the size of the device in the abdominal aorta, but right now equipment is really evolving to smaller and smaller sizes, and the vascular surgeons are getting pretty good at finding a stent that can place even in small children.
I think brachial trauma was pretty well covered by Tim, but basically treatment from the surgical standpoint is based on their presentation. You need to recognize that there's a difference between a pink pulseless hand and recognize that these are often associated with vascular injuries. There's a current algorithm that supports non-operative management for pink pulseless hands, and I think the algorithm that's being put forth by the committee is really gonna change and update the way we care for those kids.
So iliac artery injuries are rare and usually associated with penetrating trauma. You're going to want to access those through the abdomen, and you can use manual compression for both distal and proximal control before you can actually get vessel loops around the common iliac artery and the external and internal iliac arteries. Bilateral iliac injuries can be very difficult, but definitely something that we see. To repair those, you do want to do total pelvic vascular isolation, and you're going to have to cross-clamp the distal aorta and the vena cava, as well as both the external iliac arteries and veins. These are good cases where there's a role for harvesting the hypogastric artery if needed, and these are blunt injuries can usually be caused by dissection or vessel thrombosis. And if you get in there and you have an iliac artery injury and you can't repair it, please remember that you can always use temporary arterial or venous shunts.
So, popliteal artery injuries are a challenge, and part of the reason that these are such a challenge is that they're rare in children. There are only about 20 cases in the U.S. per year. About 74% of these are the result of blunt injury, and they're often associated with posterior knee dislocations. These tend to be older children. They tend to be very heavy male children, about 70% in male, 49% of the patients are white. The mean BMI is close to 30. Vascular injury and posterior knee dislocations occur in about a third of patients, and the vast majority of those undergo repair. Fasciotomies are needed in about half. Concurrent nerve injury occurs in a third, and unfortunately, lower extremity amputation is about 7% of these posterior knee dislocations. Subclavian
artery injuries are also very rare but can be very difficult to get too, because that endovascular stenting really is the mainstay of therapy and our first line recommendation. They sometimes can be very difficult to get across antegrade, and so you can use the retrograde access, which is the Galani's approach. This is where you're actually going to put a wire through the radial artery, get across the injury from the hand area, and then you're going to snag from the proximal area to do your stent placement. If you can't get this done endovascular, a sternotomy is definitely the way to go. It's a more familiar approach for most pediatric surgeons, and you can extend that as needed to make sure you have full access to the injury.
So general repair principles, we borrow a lot from the microvascular principles. We remove the adventitia completely. We do high-powered loop magnification if we're not using the microscope. It's always an interrupted anastomosis, so keep in mind that your patient's going to grow and you don't want to use a running suture that will later constrict them. Proximal and distal thrombectomies are important. The smallest Fogarty catheter is a size 2, and so if it's too small for a Fogarty, you can consider using an angiocath, as Dr. Schaub mentioned earlier. Doppler interrogation past the anastomosis is critical because you often do not get Doppler signals back at the time of repair, even if it's an accurate, a well-done repair. And so consider doing a completion arteriogram. What you're looking for on the arteriogram is you're looking for the vessels to taper to an end and not come to an abrupt cutoff that would indicate that there's residual clot.
Other operative pearls to think of is fasciotomies are often needed, and this is more so than I remember from the adult population. So if you think about fasciotomies, you should probably go ahead and do them. It's always better to replace than to bypass. It's really important to try to use native vessel if you can. So if you can replace, you should rather than bypass, even if that means just putting in a vein graft to make the vessel larger. You always want to take your vein from the opposite leg to decrease pore inflow. Popliteal retractors can be very helpful, and you can see a picture down in the corner. If you're doing a popliteal repair, often that artery is very far away from the incision that you made. You never want to use PTFE behind the knee, and always take more vein than you need because the leg is going to be bent, and when you straighten it, you'll need more length.
So reverse saphenous grain is always preferred. You can tolerate a bit of redundant artery, and it's okay as long as it doesn't kink. So a little excess artery on a vein graft in a popliteal repair is okay. If you really don't have enough vein length, you can do a composite graft where you take PTFE and use that on the proximal portion, and then sew the saphenous grain to the graft, and then the saphenous vein to the artery itself. So those are composite grafts if you really don't have other options.
And always remember, damage control in pediatric vascular trauma can definitely get you out of a tight spot. It's okay to shunt until you get the right people there. As everybody here knows, every children's hospital has a different makeup of who's doing their vascular repairs, be that a pediatric surgeon, a plastic surgeon, or a vascular surgeon. So it is okay to shunt, keep the blood flowing, and then get the right people there to do the right repair. If you don't have shunts available, you can use small chest tubes, and you can see those pictures here. We all have those little chest tubes for our babies, and these are great options for shunting.
Fasciotomies, it's really important that you treat compartment syndrome. If you don't, that entails a serious morbidity, loss of function. Those patients can go into rhabdomyolysis, multi-system organ failure, renal failure, and require additional surgeries. And unfortunately, that failure to do fasciotomies can result in a functionless limb that needs to be amputated later. Dave Feliciano once said, "I've never regretted doing one, but I've regretted not doing one." Well, thank you. We appreciate the opportunity to present this coordinated work from the Society for Vascular Surgery and for APSA. Thank you.
And we have a few minutes for questions if anyone has one. And if you're interested in pediatric vascular surgery, please contact myself or Dave Rothstein. We're putting a good group of people together to continue the work with SVS. Go ahead.
Hi, Nigel Hall, Southampton, UK. This is a fabulous session. Thank you so much for putting it on. Question for the first speaker about the iatrogenic injuries, particularly the occlusive thrombi related to arterial catheterization. we've had quite a lot of experience and pretty good results with conservative treatment that also includes thrombolysis. I didn't see much mention of thrombolysis in your algorithm. I think it was down right at the end of one thing. I suspect most of us don't have access to fantastically skilled microvascular surgeons such as you. And so I just wondered if you could comment on the role of thrombolysis versus microvascular exploration in these smaller patients.
I think it's a great question. And I think that there are a couple components to that. I think one is in those patients that are amenable to it, that don't have contraindications to it, I think it's a great option. And I think that's one of the things that, one of the tweaks you really need to make to this algorithm is when you don't have that opportunity for microvascular surgeon to help you, what are some other options? And I think that's one of the key components we need to add to this algorithm. But the other thing is I would encourage you is to find someone in the community that potentially could help you. Basically, any hand surgeon can do these. You guys are awesome at doing the approaches and being able to expose the vessel. And pretty much any hand surgeon or microvascular surgeon that does breast reconstruction can do these anastomosis for you under the microscope. So I think partnering with those people in the community would be a great way to help alleviate that need.
Hey, great session. Matt Harding from Houston. Quick question. So you do your perfect repair, and now you're post-op. Anticoagulate? No anticoagulate. Clearly controversial in the literature. See, you knew I was going to ask this. You're not sure. It's a tough thing to do, so I always struggle with this. Appreciate it.
Well, so part of the reason it's not in our slides is that we really wanted to try and present some degree of data, and anticoagulation after these repairs is a data-free zone. So what I can tell you is that we are generally using heparin as first-line therapy, and when they don't respond, then we're doing operative, and then after operative, depending on what exactly the injury is, there's a lot of variability whether we continue heparin and then transition to aspirin or not. So I cannot offer you any data. I can just tell you that we're kind of all over the place. And I don't know, Tim, do you want to comment on that for your stuff, for your tiny little stuff?
So one of the things that's very controversial is using aspirin in kids, right? And so we run into that quite a bit because of Rett syndrome. But we typically, for anastomosis, because it takes 72 hours to get a single layer of intima across the anastomosis, for microvascular anastomosis anyway, typically we'll do aspirin for at least 2 weeks, but a minimum 3 days. As far as heparinization goes for revascs, I typically will try to stop it by 5 days if I can. But for most patients, that's typically what we're trying to shoot for is for 5 days on revascs.
I think we can take
I have
one
a
more
question
question.
on iatrogenic injuries. Iatrogenic? Go ahead. May I? We see a lot of extravasation from IVs in, say, legs. After we do the compartment exposure and open them up, is there any role for heparin?
I'm sorry, after compartment syndrome?
Yeah, we see a lot of extravasation, and they have compartment syndrome. We do the fasciotomies. Is there any role after that for the use of heparin because of the compressive pressure that was exerted on the arteries and the veins?
Yeah.
Heparinization after doing your fasciotomies, continuing heparin?
With no vascular repair.
Oh, with no vascular
No
repair.
vascular repair.
I don't see one personally. If you have perfusion afterwards, there's been no repair, there's been no intimal damage. I don't see a role in doing continued heparinization personally.
Thank you.
Would agree. Thanks.